Good morning. I want to thank the organizers for inviting me. I was here last year, and this is a wonderful conference, so thank you again. All right, I do not have only one conflict of interest here. Here's my brief outline. I'm going to give you the update on immunotherapy in non-small cell lung cancer as of 2026, highlight some new novel immunotherapy agents, talk about novel chemotherapy approaches, and touch on initiatives of immunotherapy as a preventive agent. So in essence, there has been no new regulatory approvals of any IO agents since last year across stage 2 and stage 4 disease. There are no IO agents approved for the treatment of stage 1 lung cancer, but the key message from this slide is that we have numerous promising agents in the pipeline, and I'm confident that we will break through our IO plateau in the years to come, and even maybe perhaps this year. So here are the approved agents that are typically used around the world. China has additional agents. I do want to point out here that there are now subcutaneous formulations of these agents, and that is really a benefit to our patients. Here is the current status of immunotherapy in stage 4 disease. First of all patients should have their tumor tested for PD-L1 by IHC. This is because it does make a difference in treatment. If you have a high PD-L1 greater than or equal to 50%, you can receive monotherapy. For patients whose PD-L1 expression is 1 to 49, it's chemotherapy plus immunotherapy most of the time. And for those patients who have a PD-L1 that is less than 1, it's really, you can use a variety of regimens. I would say that I particularly favor an IO-IO combination with or without chemotherapy. And you can see that I've divided this here between non-squamous and squamous because the chemotherapy backbones are different. In stage 3 disease specific regimen, durvalumab after concurrent or sequential chemoradiation remains the standard of care. We are evaluating combinations. The atezolizumab tiragolumab trial, which is an anti-TIGIT, Skyscraper 3, was reported negative in 2025, but there is the Pacific 9 study that is looking at 2 additional novel combination regimens. Where most of the debate going on right now is in the resectable stage 2 and stage 3 disease. We have 3 different regimens of administration. You can give IO in the adjuvant setting, you can give it neoadjuvant, and you can give it in this perioperative setting. Now here is the data from these trials, and you can see that all of the trials met their primary endpoint of DFS. But when one looks at overall survival, in the red you see that KEYNOTE-671 was positive, and that was a dual primary endpoint. And then last year we also heard that CheckMate 816 met its endpoint for overall survival. So CheckMate 816 versus KEYNOTE-671. There was an additional trial in the adjuvant space, which was completely negative, and that was the BR31 study. I would say that while there is a role for adjuvant IO, there has been movement to the neoadjuvant regimens. Now, the hottest topic, again, is around what else can we do? In the adjuvant setting, one thing is that this is a sequential regimen. We know that when you give IO with chemotherapy, there's at least additivity or more. And so these 2 trials have been conducted. We saw some preliminary results from that Nadim adjuvant study. It's early interim analysis. The problem with this study is that the control arm is chemotherapy alone without now the standard of adjuvant IO. And so the Alchemist IO trial does have the current standard of chemotherapy followed by IO versus concurrent. So we'll wait to see the results of the Alchemist IO study. Now, one of the probably hottest debates that we have is patients who receive neoadjuvant chemo IO, do they need adjuvant IO after surgical resection? And here is the ETOP study, Adopt Lung trial, that will definitively answer the question by randomizing patients to durvalumab or observation. In the United States, we have taken a different approach to where we are looking at patients dependent upon did they or did they not get a complete pathological response to neoadjuvant therapy. And SWOG took on the trial of the patients who have pathological complete responses, and they're randomized to durvalumab versus observation. Now, the exploratory analysis of the randomized trials have shown that it is unlikely that these patients would need additional adjuvant therapy. And here is also a retrospective study looking here that the relapse rate was 8.5% in this Japanese study. And so it does appear to be very small, but this trial will give us the definitive answer. ECOG was running the non-path trial. This was just closed because the phase 3 trial in advanced stage lung cancer with the novel agent of serelazasertinib was negative. Now, what about stage 1? As was said yesterday, there is no systemic therapy for patients who have tumors that are less than 3 centimeters. If your tumor is between 3 and 4 centimeters, adjuvant chemotherapy for those patients who have a clinical or pathological high-risk feature is recommended. And here are some data from Japan that supports that recommendation. Now, we did see last year at ASCO a prospective trial that looked at a high-risk feature, and that was a 14-gene expression profile. Those patients who had higher intermediate profile was randomized to chemotherapy or observation. In the first interim analysis, 24-month disease-free survival in the overall population and in the pre-specified population with stage 1 does appear to favor the cytotoxic chemotherapy, but we need to get longer follow-up on this study. Now, there is not, as I said, any immunotherapy trials that have been positive, but there are trials in progress. One is a randomized phase 2 with Pembro, another one with a PD-L1 inhibitor, small study in China looking at grade 3 invasive adenocarcinomas, and then this most interesting study, the phase 3 Tropion Lung 12 study, which is looking at an anti-TIGIT agent, rilvegostomig, and an antibody-drug conjugate to TROP2, which is Dato-DX. And what's interesting also is not only the combination, which is novel, but this is being conducted in those patients who have MRD positive or poor prognostic factors. Now, this is a nice segue into some of these promising novel agents. And there are many classes of novel immunotherapy agents. I'm only going to talk to you about 2. The first one are bispecific antibodies. The first bispecific antibody that I'm going to talk about is this bispecific antibody with PD-L1 or PD-1 and CTLA-4. You can see that there are many of these agents in development. I'm going to point out volrustomig. There is some small data from this phase 2 trial that is promising for the combination with chemotherapy. And now there is a randomized phase 3 trial being conducted in advanced stage lung cancer. All right, the most exciting bispecific antibody is that with a combination of a PD-1 and a VEGF target. And the hallmark here is this drug, ivonescimab. Ivonescimab, as you can see in the red highlight, in a randomized phase 3 trial conducted in China, was superior to pembrolizumab alone. So it is the first drug that has kind of broken through that IO pembro plateau that we have. And you can see that in phase 3 trials here in first-line advanced lung cancer, there are numerous studies ongoing. So this is really, we're very excited about these bispecific antibodies. And of course, you can make a whole host of bispecific antibodies. Now, the second one is cancer vaccines. Based upon the results from the melanoma trial, Keynote 942, where patients were randomized to this mRNA vaccine plus Pembro versus Pembro alone in resected melanoma patients. That trial was positive, and we just heard the 5-year update, and that is also keeping that significant DFS significant for the vaccine plus Pembro. So that exact same vaccine is being used in non-small cell lung cancer in the adjuvant space and in the non-pathological adjuvant setting. So INTERPATH 002 and INTERPATH 009. Finally, I'm a little bit over time, but here is something new. Cytotoxic chemotherapy, old now new. With the advances in technology, we were able to make a monoclonal antibody that has a linker to a cytotoxic payload, and the antibody then hones to its tumor-specific antigen. When that binds, that complex gets internalized, the linker gets degraded, and the cytotoxic payload can then attack the cancer cell. Of course, we get more drug to the tumor without less toxicity is the principle here. And this is really a very exciting field. There are 510 studies with a variety of antibody drug conjugates. There are 2 approved, but they are approved in the actionable mutation space, one for HER2 and one for EGFR. And then finally, I showed this last year, here are some trials of immunotherapy to try to prevent lung cancer, one with Pembro and the other with canakinumab, which is a interleukin IL-beta. And then this year, there will be a study that will be opening up, and that's the LungVax trial in the UK, a small study. This will be the first study really looking at a vaccine. I'm going to skip this slide and go to my last slide and hope to see all of you at Seoul, Korea for WCLC 2026. Just a reminder, abstracts are due April 1st, and early registration has now opened. So you can register today. Thank you.